Hello guys, and welcome to another video from MedTube on respiratory acidosis. First of all, please note that respiratory acidosis is not really a part of nephrology, but rather a part of the acid-base disturbances, and this is why it is included in the nephrology playlist. So starting with the definition of respiratory acidosis, it is an increase in the PaCO2, which is the partial pressure of the arterial carbon dioxide secondary to hypoventilation, and the normal PaCO2 is 35 to 45 millimeters of mercury. A respiratory acidosis could be either acute or chronic, and that depends on the duration of the symptoms and the response of the body to the primary disturbance, which is also known as the compensation. And please note again that all the compensations of the acid-base disturbances will be explained at the end of the series. Now there are 5 main etiologies by which respiratory acidosis occurs, and those are respiratory center depression, neuromuscular disorders, airway obstruction, parenchymal diseases, and finally mechanical hypoventilation, and any of those could result in respiratory acidosis. And finally, there is a very important concept, which is the following: hypercapnia, which is the increase in the PaCO2, is not necessarily always due to hypoventilation, which is respiratory acidosis, but it could be due to other etiologies such as pulmonary embolism, in which there is a ventilation perfusion mismatch, or it could be due to fever, thyrotoxicosis, sepsis, or even exercise, all of those 4 which increase the production of the carbon dioxide, and it could be due to other causes. And if you notice, all of those causes are actually associated with hyperventilation, and despite the hyperventilation, they still develop hypercapnia because of the mechanisms I have just said. Now let's move for the etiology of respiratory acidosis. And again, we have the 5 categories, starting with the respiratory center depression, the neuromuscular disorders, the airway obstruction, the parenchymal diseases, and finally the mechanical hypoventilation. So starting with the respiratory center depression, we have a variety of causes. And first we have the drugs such as the anesthetics, the sedatives such as the benzodiazepines, and the narcotics such as morphine. And then we have trauma affecting the brainstem respiratory center, and then we have increased intracranial pressure, encephalitis, stroke, central apnea, oxygen use in chronic CO2 retainers, all of which have the potential to cause respiratory center depression in the brainstem. And then coming to the neuromuscular disorders, and we have a pretty long list, starting with myasthenia gravis, which is autoantibodies directed against the postsynaptic acetylcholine receptors, resulting in weakness. And then there's the Guillain-Barré syndrome, which is demyelination of the peripheral nerve fibers. And then we have poliomyelitis, which is caused by the poliovirus destroying the anterior horn cells of the spinal cord, resulting in lower motor neuron lesion. And the next one is botulism, and botulism is caused by toxins released from the Clostridium botulinum, inhibiting the acetylcholine release at the neuromuscular junction. And then we have tetanus, which is also due to a toxin named tetanospasmin released from the Clostridium tetani, and this toxin inhibits the release of the inhibitory neurotransmitters such as glycine from the Renshaw cells in the spinal cord, and therefore causing spastic paralysis. And this is in contrast to botulism, which causes flaccid paralysis. And then moving to ALS, Amyotrophic Lateral Sclerosis, which is a degenerative motor neuron disease including both upper motor neuron lesions and lower motor neuron lesions. And then we have the muscular dystrophies such as Duchenne muscular dystrophy, and then we have the myopathies, and the myopathies are either congenital or acquired. And we have a long list of congenital causes including the dystrophies. So the dystrophies are actually part of the myopathies, or the myopathies could be acquired as a side effect of certain drugs as in steroids or alcohol, or certain conditions such as polymyositis, dermatomyositis, and many other examples. And then moving to the thoracic cage disorders, and I have marked it in red just because many examples fall under this category, such as obesity, kyphoscoliosis, flail chest, ankylosing spondylitis, pectus excavatum, or pectus carinatum. So in a nutshell, all of those will cause limitation of the chest movement. And then we have the metabolic causes such as hypophosphatemia and hypomagnesemia, both of which may induce inspiratory muscle myopathy. And now moving to the airway obstruction category, and pretty much the most important are the COPD causes, which are emphysema, chronic bronchitis, and severe asthma, all of which are obstructive lung diseases. Now those other causes which I have marked in orange, they are actually causes of airway obstruction causing hypercapnia, not causes of airway obstruction causing respiratory acidosis. So they actually fit better in the bottom of the previous slide when we have talked about hypercapnia due to causes other than the hypoventilation. And those are laryngeal or tracheal stenosis or angioedema or obstructive sleep apnea or obstructive goiter or foreign body aspiration, all of which cause airway obstruction causing hypercapnia without hypoventilation. And now let's move to the parenchymal diseases. And again we have the COPD, pulmonary edema, pneumothorax, pneumonia, interstitial lung disease, and ARDS, which is acute respiratory distress syndrome, all of which impair alveolar gas exchange due to different mechanisms. And finally we have the mechanical hypoventilation category, which is either due to inadequate mechanical ventilation in intubated patients or due to permissive hypercapnia, which is deliberately inducing hypercapnia by decreasing the tidal volume or decreasing the respiratory rate, and that's to prevent barotrauma in predisposed patients such as intubated patient with ARDS or an intubated patient with COPD. This is all for respiratory acidosis in summary, and please note that as in all videos, this aims to give you an overall view on the etiology but not a complete comprehensive list of causes. And now let's move to the management of respiratory acidosis, starting with the history taking. Starting with a review of systems, asking about any cough or sputum production such as in COPD patients or pneumonia or interstitial lung diseases or other lung pathologies, and then we ask about any dyspnea or fever such as in pneumonia or encephalitis, and then ask about any weakness as in stroke patients or myopathies or myasthenia gravis or even Guillain-Barré syndrome, and then ask about any paresthesias as in strokes again or Guillain-Barré syndrome, ask about any recent head traumas or neck traumas, and ask the patient about any confusion which could indicate hypercapnia itself, which is common in moderate to severe hypercapnia, and ask about any past medical history of any COPD or other lung diseases or any neuromuscular disorders which were described in the previous slide, or any recent intake of sedatives as in benzodiazepines or narcotics as in opioids as morphine. And then moving for the physical examination, and of course the first thing we would look for is the vital signs and assessing the respiratory rate, which of course we would expect it to be low, that is in general below 12 breaths per minute, and assess the patient for any delirium or confusion which are commonly seen in hypercapnic patients, or even myoclonus and seizures which occur in severe hypercapnia. And then of course we would perform a complete chest examination starting from inspection, palpation, percussion, and auscultation. And in inspection, it's very important to look for any signs of respiratory distress and abnormal chest wall movements. And of course, we would also perform a complete neurological examination, assessing for the GCS, the Glasgow Coma Scale, and assessing for any muscle weakness or sensory deficits. And then we would inspect the patient for any obvious thoracic cage disorders, as in obesity or certain deformities. And then we look for cyanosis, which indicates any coexisting hypoxemia in the patient. And finally, we would perform an ophthalmoscopy, looking for any papilledema, which could indicate an increased intracranial pressure. And then we move for the investigations, and of course we would start with the pulse oximetry, and that's to look for hypoxemia, because many of the respiratory acidosis patients, they do not merely present with hypercapnia but also with hypoxemia, and that's because of impairment of both ventilation and oxygenation. And then we would perform a quick bedside spirometry, looking for any restrictive or obstructive lung pathologies. And then we perform, of course, an ABG, a very important test, assessing for the acidosis and the compensation. And of course, we measure the AA gradient, which is the alveolar arterial partial pressure of oxygen gradient, especially if the patient has hypoxemia, as it helps in differentiating the different causes of hypoxemia. And then we perform the metabolic profile, of looking for electrolytes in general. And we measure the CBC, looking for any signs of infection. And finally, we definitely need to do a chest radiograph looking at the lungs, and if the chest radiograph is inconclusive, we will also go for a CT scan of the chest. And later on, once the patient is stabilized, then we would go for a full set of pulmonary function tests in a proper hospital setting, and we would also consider, if needed, an EMG, which is an electromyography, and even an NCS, which is nerve conduction studies. And now let's move to the treatment of respiratory respiratory acidosis. And the treatment in general should aim to treat the underlying cause. For example, if the patient is suffering from COPD, then we will give bronchodilators. If the cause were pneumonia, then we would give antibiotics. If the cause were a benzodiazepine overdose, then we would give flumazenil. And if the cause were an opioid overdose, then we would give naloxone, and so forth. And if the patient has a severe hypercapnia, then we would go also for non-invasive ventilation or even invasive mechanical ventilation, especially if the PaCO2 is above 50 millimeters of mercury. And finally, if the patient is also suffering of hypoxemia, then we would supplement the patient with oxygen, preferably through nasal cannula, with a target oxygen saturation of 90 to 93%. And one final point to make is that you should be careful when using oxygen with COPD patients, because the oxygen can aggravate the hypercapnia through inducing ventilation perfusion mismatch in the lungs. This is all for the management of respiratory acidosis in summary, and this is the end of respiratory acidosis video, and I hope to see you again on our next video on respiratory alkalosis. Thank you.